Hi, my name is Rebecca, and I'm a graduate teaching assistant at the University of Kentucky for the Department of Kinesiology and Health Promotion. In today's lab, we will learn how to assess an individual's heart function through an electrocardiogram, or better known as an ECG. An ECG is a non-invasive measurement of the electrical activity of the heart. The ECG provides a recording of the heart activity through surface electrodes. This does not introduce an electrical current to the body, but instead produces a tracing that better allows us to measure and analyze heart function. ECG tracings are used by exercise physiologists, cardiologists, cardiac rehab specialists to examine heart function. Therefore, the purpose of this lab is for you to become familiar with the procedures, preparations, and interpretations of an ECG tracing during rest and during postural changes. Now, before we get started and get into this lab experiment, let's review some anatomy and physiology of the heart. Keep in mind the heart is typically located just to the left of the center of your chest and is slightly tilted to the right. An ECG measures the electrical activity of the heart on the surface of the skin. As you know, a cardiac cycle, all of the events of one heartbeat, consist of systole, contraction, and diastole, rest phases. Contraction of the myocardium are stimulated by cardiac myocyte action potentials that cause a depolarization of the sarcolemma, followed by repolarization and then a return to resting membrane potential. The electrical activity or movement of the ions across the cell membrane can be recorded by the electrodes placed on the skin. During normal heart function, the electrical wave of depolarization is initiated by a special tissue called the sinoatrial node, or the SA node, often called the pacemaker of the heart. The wave then spreads in all directions of the atria, but also spreads quickly towards the left of the atria. When the wave of the depolarization reaches the atrioventricular node, or the AV node, a brief pause in the electrical conduction occurs. This allows the atria to contract and push blood into the ventricles. Then, the electrical current continues from the AV node down to the bundle of His and then spreads to the ventricle wall via the left and right bundle branch and Purkinje fibers. This initiates ventricular contraction, which is ejection of the blood, or also known as systole. As the cells depolarize, they must repolarize and return to their resting membrane potential. The phase between contractions is called diastole. What exactly does depolarization of the heart mean? Resting membrane potential of ventricular myocytes is about negative 90 millivolts at rest. When an action potential is generated, the membrane potential rises above this level in 4 distinct phases: depolarization, plateau, repolarization, and then back to baseline. Depolarization, the cell membrane is becoming more positive, plus about 50 millivolts. Repolarization is when the cell membrane becomes more negative, about negative 90 millivolts. We are able to see and record these changes in membrane potential by measuring them with the electrodes. These electrodes will generate tracings in which we call them the leads of a 12-lead ECG. Now, at this point, you might be wondering what an electrode is. An electrode is a small egg-like or round-shaped sticker with a gel center. Each electrode is placed at a specific location on the skin and has a metal snap where the ECG machine wires are connected. This allows the electrical recording of heart activity to be transferred from the ECG device to a tracing on graph paper for further analysis. We will typically use 10 electrodes to give us a 12-lead ECG. Now you just learned about what an electrode is, now let's learn about what a lead is. Each ECG lead consists of 2 poles in which an electrode is designated as a positive electrode. A positive electrode measures the direction and the amplitude of the electrical waves that are traveling in the heart during the ECG recording. Now, in a 12-lead ECG, there are 6 limb leads and 6 precordial or chest leads. Each lead provides us with a different view of the heart. Therefore, we have 12 different views of the heart's activity. However, we only need to place 10 electrodes, 4 limb electrodes, and 6 chest electrodes to perform a 12-lead ECG. The lead tracings tell us the direction of depolarization. If a wave of depolarization of the myocardium is moving towards the positive electrode of a lead, an upward or positive deflection in the ECG tracing will appear. If a wave of depolarization is moving away from the positive electrode in the lead, a downward or negative deflection will result on the ECG tracing. Now for the lab experiment. For this lab experiment, we will discuss skin preparation, electrode placement, and observe a resting ECG and changes that occur when the subject goes from supine to standing. Skin preparation. Before you place the electrodes on the skin surface, you want to make sure that you have a very clean surface area. Start by removing any hair by shaving the part of the chest where the electrodes will be placed. Next, remove any dirt or dead skin with a small abrasion pad or sandpaper. Lastly, clean the site with a small alcohol pad. This may sting a little, but we want to make sure that we are removing any excess from the skin. This provides for better conduction during the ECG. For electrode placement, a normal or non-modified ECG test would have us place the 4 limb electrodes at the base of the ankle and each wrist. However, during exercise, we place the limb electrodes on the torso for a modified ECG. Therefore, for the purposes of this lab, we are performing a modified 12-lead ECG test. We will place the limb electrodes first. The right arm is placed just below the midpoint of the right clavicle. The left arm placed just below the midpoint of the left clavicle. The right leg is placed in line with the right arm electrode on the torso just below the final rib. And the left leg electrode is placed in line with the left arm electrode on the torso just below the final rib. From these 4 electrodes, we get 6 different leads of the heart's electrical activity. Or we can think about this as 6 different frontal plane views of the heart's function. These 6 leads are divided into 2 groups: bipolar leads, both positive and negative, and augmented leads, only a positive electrode. You can see here we have lead 1, lead 2, lead 3, AVF, AVL, and AVR. Lead 1 is created by the right arm and left arm electrodes. The left arm is positive and the right arm is negative. Lead 2 is created by the right arm and left foot electrodes. The left foot is positive, the right arm is negative. This lead is also known as the rhythm strip because it views the heart's waves of depolarization as it travels through the primary conductive system. The last of the bipolar leads is lead 3. This is created by the left arm and the left foot electrodes. The left foot is the positive and left arm is negative. Next, we have our 3 augmented leads: AVR, AVL, and AVF. AVR records the wave of depolarization of the heart moving perpendicular from lead 3. The right arm is the positive electrode. AVL records the wave of depolarization moving from the heart perpendicular to lead 2. The left arm is the positive electrode. And AVF records waves of depolarization of the heart moving perpendicular from lead 1. The left foot is the positive electrode. Each of these leads passes through the AV node. Therefore, we get 3 bipolar and 3 augmented ECG tracing. Now we will place the chest electrodes. These leads all give us a horizontal or transverse plane views of the heart and are considered to be unipolar. We refer to these leads and electrodes as V1 through V6. Each is placed in an intercostal space, the space between ribs. To locate the intercostal space where you are to place the electrodes, first find the participant's sternal notch. Slide your index finger to the right, past the sternum, then bring your finger down until you feel a soft tissue space. This is the intercostal space. The 6 chest leads are V1, where the electrode is placed close to, but not on the sternum, on the right side of the sternal border, placed in the 4th intercostal space. Next, lead 2 is placed directly across from V1, again, placed close to, but not on the sternum, on the left side of the sternal border. This is also placed in the 4th intercostal space. We then skip V3 and move directly to V4. This electrode is placed in the midclavicular line in the 5th intercostal space. Now we can come back to V3. Even though this is out of order, we want to place V4 first, so we can place V3 directly between V2 and V4. V5 is placed on the anterior axillary line of the 5th intercostal space. V6 is placed on the mid-axillary line of the 5th intercostal space. Now that we have the electrodes placed, we can connect the ECG machine wires to their designated electrodes. Each wire is labeled with its corresponding limb and is universally color coordinated. The right arm is white and the left foot is green. This is easy to remember by thinking white snow on top of green grass. The left arm wire is black and the left foot wire is red. You can think of smoke over fire to remember the left side. The right leg acts as the ground electrode. This wire and electrode must have good connection for the ECG tracing to be seen on the monitor. Similar to the limb electrode wires, the chest electrode wires are also labeled and color-coded universally. We have now placed all 10 electrodes and connected all 10 wires. On the monitor, we will see 12 ECG tracings and are ready to view our subject's ECG. Alright, now that we have successfully prepped the skin and prepped our subject for the ECG, all electrodes are placed and wires, we can now continue with the lab procedures. We will observe any changes in the ECG recording as our participant changes positions. The 2 positions we're looking at is a resting ECG during a supine position, which is our subject laying flat on their back, and then in a standing position. The participant will start in a supine position and continue to lay as still as possible for the remaining 2 minutes. These 2 minutes allow the heart rate to get back to a resting baseline. At the 2-minute mark, or when the heart rate becomes steady, we will continue to print the ECG tracing. Once the script is printed, we have the participant stand straight and remain as still as possible. Once the participant stands, check the ECG machine for any major abnormalities to ensure the electrodes and wires remain connected. Once you see a clean ECG tracing, you can start to print. Now we can compare the 2 scripts to look for changes during the supine and the standing ECG. Now that our subject has completed the procedure, let's examine the different components of the ECG tracing during a single cardiac cycle. An ECG tracing consists of segments, complexes, and intervals. The P wave represents atrial depolarization. The PR interval represents the ECG tracing from the beginning of depolarization of the SA node to the initiation of depolarization of the AV node. The PR segment represents a brief delay in the depolarization when the electrical activity initiated in the SA node arrives at the AV node. The QRS complex represents ventricle depolarization. Next is the ST segment. The ST segment represents the initial portion of ventricular repolarization. In a normal functioning heart, the ST segment should be flat with the isoelectric line, or at least within 1 millimeter of elevation or depression. The T wave represents the final portion of ventricular repolarization. And the QT interval represents waves of depolarization from ventricle depolarization to ventricle repolarization. An ECG tracing can provide information to determine heart rate, as well as amplitude and duration. Each of the cardiac cycle component has a specific amplitude and duration it needs to stay within. The ECG tracings are printed on graph paper, which is divided into large and small boxes. Each large box is 5 millimeters, representing 0.5 millivolts and 0.20 seconds. Each small box is 1 millimeter, representing 0.1 millivolts and 0.04 seconds. Determining heart rate from an ECG recording is identifiable by what is reflected as the R to R interval. The R inflections of the QRS complex from 2 cardiac cycles. To determine heart rate, you will find the R peaks of 2 consecutive cardiac cycles. Then you will count the number of small or large boxes between the 2 R peaks. If you choose to use the small box method, you will take 1500 divided by the number of small boxes between the R peaks, or the number of small boxes within the R to R interval. If you choose to use the large box method, you will take 300 divided by the number of large boxes between the R peaks or within the R to R interval. Same ECG printout or graph can also be used to determine the amplitude and duration of various components of the cardiac cycle. Knowing this information can help a clinician determine if the heart is functioning normally or if there are any abnormalities. Normal amplitude and duration of the ECG components are as follows. A P wave, the duration should be less than 0.12 seconds or 3 small boxes, and the amplitude less than 0.25 millivolts or 2.5 small boxes. The duration of the PR interval should fall in between 0.12 seconds to 0.2 seconds, or 3 to 5 small boxes. The QRS complex, the duration should be less than 0.12 seconds, or 3 small boxes, and the amplitude of the QRS complex should be less than 0.25 millivolts, or less than 2.5 small boxes. The normal range of amplitude for the ST segment should be less than 1 millivolt, whether it's depression or elevation. The QT interval is rate dependent, and this is the duration should be less than half of the R to R interval. So, in summary, the purpose of this lab was to become familiar with preparation and procedures of a 12-lead ECG, as well as reviewing the physiological changes in the heart's electrical activity at rest and during postural changes. You should also be comfortable with reading and interpreting an ECG recording. For your lab, your TA will provide you with the data from today's experiment, and you should complete the same laboratory experiment performed in this video.